Hello and welcome to the first episode of Wound Care Legends of India, where we delve deep into the experiences, insights, and stories of the pioneers who have shaped our wound care in India. I'm your host, Dr. Sanjay Sharma, and today we have a very special guest who is a true legend in the field of plastic and diabetic foot surgeries, Dr. Sanjay Vaidya. व्रणनाम उपचारो हि कर्तव्यः धर्मनिष्ठयः युक्तिसिद्धं चिकित्सार्थं स्वास्थ्यम आरोग्यमेव च. Wound care should be performed with steadfast adherence to dharma, using appropriate methods and ensure overall health and well-being. This is what Dr. Sanjay Vaidya has been doing all through his career. Dr. Vaidya has been at the forefront of diabetic foot care since 1988, with career spanning over 3.5 decades. His expertise in the assessment, diagnosis, and surgical treatment of the complex foot and lower limb conditions has transformed the lives of countless patients. From minor wound debridement to complex reconstructive surgeries, Dr. Vaidya's work has set a standard for excellence in wound care. But what truly sets Dr. Vaidya apart is not just his professional achievements, but also his journey into medicine, a path that began many years ago during his student days. In today's episode, we will explore what drew him into the field of medicine, especially the plastic surgery and diabetic foot surgery, as well as the challenges and inspirations that shaped his early career. Not just this, we will also discuss the pivotal moments that led him to specialize or his keen interest in diabetic foot care and how he has continued to push the boundaries to the field with innovative technologies and surgical techniques. Beyond the professional journey, we'll get a glimpse into his personal side of Dr. Vaidya, how he balances his demanding career and his personal life, his interests outside of medicine, and the values that have guided him throughout his life. Without further ado, let's welcome Dr. Sanjay Vaidya to the show. Dr. Vaidya, thank you very much for joining us today. To start with, could you take us back to your student days? What initially inspired you to get into medicine itself?
During my childhood, I have seen my father's close friend who was a doctor who went on to become dean of one of the medical colleges, and he was truly a role model for me, and from childhood days I always aspired to become a doctor.
Why plastic surgery?
Well, the moment I entered medicine, during first MBBS, when I started doing the dissections in anatomy, I realized my passion is going to be surgery and not medicine. By the time I entered surgery, general surgery, by the time I had a good overall view of different branches, including cardiac surgery, neurosurgery, and then somehow I felt my temperament, passion, I think I belong to plastic surgery cadre.
So, when we all know about plastic surgery today, it is more about aesthetics or cosmetic surgeries, and aesthetics is what people are synonymous with plastic surgery. But you are known as a diabetic foot surgeon. So, was that a transition? Is that related, or how did it got your interest into diabetic foot surgery?
Yes, as you rightly said, any plastic surgeon would start his career as a cosmetic surgeon, and so was my case. But simultaneously, I was also handling diabetic foot surgery cases to a lesser extent because of my mentor, Dr. Arun Bal, with whom I have been associated right from my student days, where he was a associate professor. Later on, there was a turning point in my life. I would say one turning point where it so happened that one of the cosmetic surgeons from USA, a person of Indian origin, also wanted to start aesthetic surgery practice in India, and especially in city of Mumbai. That's when he asked me to join him. Being my teacher, of course, I was fascinated. When we started discussing the nitty-gritty, he told me that you are going to do only cosmetic surgery. I came back home, thought really hard over it, and then I realized, no, that's not what I want to do all throughout my life. I would definitely like to save the patient's limbs, treat a trauma patient, treat a diabetic foot patient, and that's when I declined that offer, though our relations were absolutely cordial and we're still in good touch.
But in terms of when you declined it or when you took up the diabetic foot surgery or taking care of the wounds per se, uh, we all have seen in my career also, we have seen that because you do not know anything any other, you're not good at any other surgery, you have gotten into diabetic foot. That is what the norm is, like you have become a transplant surgeon or some other surgeon, but because you don't know any of it, you're getting into diabetic foot. Was there any kind of challenges, or how did the society or the medical fraternity around treat you, or thought about you when you chose wound care as your passion and rather than cosmetic or aesthetic surgery?
Yes, my friends were definitely surprised, no doubt about it, especially when I started declining my aesthetic surgery cases, which I was very routinely doing, and I started referring those patients to my friends and colleagues, and I said I'm going to stick only to diabetic foot surgery. That was, yes, of course, a difficult decision, but retrospectively, I'm very happy that I took that decision, because I feel it is very satisfying, because when you are treating diabetic
Absolutely.
foot patient, you are treating patients, not only patients, we are actually taking care of the whole family. When you are saving the life, you get that satisfaction, saving the limb, saving the life. End of the day, I think any doctor definitely would strive for that, rather than just doing some aesthetic surgery, doing nose jobs, breast augmentations, which of course does give you a good satisfaction as well, and a good amount more money, I would say. But this, I think, definitely gives us more satisfaction as compared to any other branch.
Absolutely agree on that. Also, we have seen that in a plastic surgery or an aesthetic surgery perspective, it is always a planned surgery that we would do. So we have our professional and personal life balance that has been there if you had chosen an aesthetic surgery, because you can tell, okay, this time would be the surgery and this is how this going. But I see that in diabetic foot surgery that might not be the case. It might not be as emergencies or as an abdominal acute appendicitis or something like that. But still, we cannot have that luxury of scheduling the surgeries at our own time many a times. So how are you trying to balance between the professional and the personal lives, having chosen diabetic foot or wound care as a specialty?
For that, I must thank my wife Vaidya, because she has been very understanding. Especially even today, it so happens that sometimes you go to take a round and see a very bad patient of necrotizing fasciitis which is being referred from outside Mumbai, and you feel it has to be operated today, and on Sunday you end up operating that patient. So that, I think, requires a lot of understanding on part of the spouse, which I am very lucky to get that support.
Awesome. So I know that you're married sometime in January.
Yes.
So how did it happen? How did you meet your wife? How did your marriage happen? These are surprise questions. Yeah.
Well, I met her in one of my friends' marriage, wherein his wife was my Meda's cousin, and that's how we came across each other. And you can say it was liking at the first sight.
Awesome. Love at first sight.
Yes.
Awesome. So, coming back to the professional discussion, we have seen that you have been presenting about diabetic foot surgeries or diabetic foot management in various of these conferences, and we have seen that your liking is towards technology.
Yes.
In diabetic foot surgery. Can you elaborate more on that in terms of how is technology relevant in terms of managing diabetic foot, and what are your thoughts on that?
Well, if I look back 4 decades back, when I was a resident in general surgery, I still remember an elderly gentleman who had come with a diabetic foot problem, infected toe wound. Those days, angiography was almost unheard of, and I remember my senior resident telling me to do the dressings, because I think as a junior most resident you end up doing those dressings. So I would keep his foot in a usual bath for half an hour, at times maybe even more, and then eventually I remember he lost his toe, then forefoot, then went on to become a below-knee amputation. Those were the days, of course, 40 years back, when many of the viewers probably were in the school or maybe were not born. Times have changed tremendously. Coming to a little fast forward to 1986 when I was a resident in plastic surgery. My bosses were always encouraging, and that time lasers were not really common instrument to be used.
Yeah.
But then somehow my boss got one of the CO2 lasers borrowed, and we operated a case of hemangioma. And in fact, that was my first ever presentation in a conference, that resection of a hemangioma using CO2 laser.
Okay.
So
Awesome.
I was fascinated with this technology right from the beginning. Somehow destiny brought me in touch with the modern technologies, and from that time I think I got hooked onto.
Was plastic surgery something influenced you to adopt to technologies? Because a lot of technologies are being used in plastic surgery or aesthetic surgery. I would
Yes,
say not
yes.
plastic but aesthetic surgery.
Yes, that's true actually. So your mind is always open to newer ideas, newer challenges, newer technologies which can give us better patient outcomes, and that's what I think probably eventually, as I told you in 1986, I used that laser. Then of course came a time when I went for studies to Moscow to learn about lasers, and that's when I saw amazing uses of CO2 laser. Not only that, low-level laser therapy, which was almost unheard of during those days in India.
Like what do we call that as a cold laser?
Yes, and that was the one which actually I brought along with me when I came back and started using for wound healing. So that was almost about 21 years back.
So there are different types of lasers that we see today which has been used in wound healing. It could be a contact laser that is being used, or a non-contact lasers that is being used, and different frequencies. Could you just talk more about what would be the most appropriate, probably for a younger doctor who is exploring that, okay, should I use laser? What could be the most appropriate laser interventions?
Okay, if you ask me, in today's technology, actually YAG laser is the gold standard when you are talking about treating a wound and getting faster wound healing. But yes, I must say that it's prohibitively expensive laser, but it gives very good results vis-a-vis a cold laser which has to be given every day. The laser has to be given once in a week, of course, along with standard wound care modality. That's very important. Like, you cannot expect a diabetic foot patient to be walking around without offloading and expecting a result with any technology for it, not only any technology for it.
Absolutely. So offloading is the key.
Yeah.
Offloading is very almost the key. And you have also been mentoring a lot of young surgeons who have been wanting to get into diabetic foot surgery. And off late we have seen, unlike in my practice also, when I started in 2013, 14 kind of a thing, and versus now, there is a lot of interest that the younger surgeons have been showing to get into diabetic foot surgery, and the interest from surgeons are varied. It could be vascular surgeons to plastic surgeons to general surgeons to orthopedic surgeons. Everyone would want to put their hand in the diabetic foot surgeries. So what's your one is advice in terms of what should they look at diabetic foot surgery as, and with a lot of them coming in, who I know it might be a bit controversial here, but who would be the right person to start dealing with diabetic foot surgeries?
Well, I being a plastic surgeon, I would always say that a plastic surgeon is the best faculty to tackle diabetic foot, because right starting from aggressive debridements, we won't look back and see how much big defect we have created, because as plastic surgeons we are trained to cover the defects. In fact,
that's interesting.
Oncosurgeon would just come and resect, and they would just take out their gloves and would say, Sanjay, now it's your job to cover that. How you cover is
interesting.
So same thing applies here in diabetic foot surgery. In fact, we need very aggressive radical debridements, and that time we will not think whether we have got an exposed bone or exposed joint. We would just go and radically debride that if you want to save the limb or take the patient out of sepsis. And then of course, as a plastic surgeon, I think you are in a better position to focus and decide how best you can cover this wound faster.
Agreed in terms of, but an integrative or what we call as an MDT is absolutely required.
As you rightly said, actually, it's not one-man job. It's absolutely completely a team job. We need a good endocrinologist, we need a good cardiologist, a good nephrologist, a good vascular surgeon or an intervention radiologist, because unless they give us a good vascularity, we can't do anything.
Yeah.
Then there are multiple factors. Patients have so many comorbidities. So unless we have a team of general surgeons, orthopedic surgeons, plastic surgeons, I mean, it's all a teamwork. And let me say one thing. I think amongst all this team, who is the most important member of the team? That is going to be the patient.
Yeah,
Because
absolutely,
unless
yeah.
we involve the patient in the whole treatment management plan, we are not going to succeed.
Yeah, and as you were saying, one is the debridement and one is the the flap or a SSG or
Right.
covers that you do and other things. So which includes a lot of surgeries for the patient.
Yes.
It is not like an appendicitis where we do once and it is done
Yes.
kind of a thing.
Yeah.
But how would you convince the patient, or how do you make him understand that okay, it includes a lot of these surgeries, twice, thrice, 4 times kind of a thing for him to be able to lead a normal life?
Well, now actually, yes, initially for beginners it will be difficult. Come to think of it, today what happens is many times I get patients who have already been operated 4 times.
Okay.
And then at the last resort, probably they are sent to our tertiary care hospitals to save the limb, or they are in really bad sepsis. In fact, sometimes even to save the life. That point of time, I don't think they will ask you how many more surgeries are required. We only say that, look, we are going to try our best. It will involve multiple surgeries. Even expenditure is huge, which we know actually, which is a very unfortunate part, because not many have the insurance cover, or by the time they reach, many times even the insurance is got exhausted.
Yeah. How would you deal with that? I know, because I also face this day in and day out, and probably many young surgeons also face this day in and day out, in terms of how do you communicate to the patient, how do you convince the patient that it is a long drawn approach, it is not one time fix all kind of a thing, it is lifestyles plus surgeries and multiple things involved.
No, what
From your experience, how would you?
No, yes, counseling is very important. As you rightly said, the first consultation, I think I would encourage not only the patient but the close relatives. Let all of them come, sit together. Then definitely we should explain to them the complexity of the situation. If there is a vascular problem, tell them this is what it is. So our plan is going to be first vascular intervention, get a blood flow going, which may or may not be optimal. Then next stage is going to be a radical debridement. We are doing a limb salvage. We'll have to see, of course, what kind of a blood flow we are getting. So at times we have to tell them, I will do a transcutaneous oxygen pressure measurements to tell you exactly up to what level we have got a good blood flow coming. Then accordingly we are going to plan the treatment. Subsequently, we are going to be on a negative pressure wound therapy or even hyperbaric oxygen therapy. So all the modalities are going to be combined, and then subsequently it will come to a stage where skin graft or flap can be planned and the limb can be salvaged. Then come the rehab part, then providing the patient with the proper orthotics, proper footwear, and during the phase when is actually immobile because of the wound, that time also we have to see how we can make the patient mobile by giving proper offloading shoes. That's where the comprehensive care comes into play.
Absolutely, and the patient will have to be convinced that it is not a 15 days, 1 week, 2 weeks kind of a thing.
Yes.
It might take a couple of months or 3 to 4 months for a complete process to be fine and he being able to walk.
Typically, if you really ask me, sometimes the patient comes to me with a wound which is about 5 years old, then I would say give me at least few months for it to heal.
Yeah, absolutely. One more thing that you mentioned about USOL when you were in the very initial days, and we believe that today it is not to be used at all. So would you throw some insights for the young surgeons here? What can be used on a chronic ulcer and what cannot be used on a chronic ulcer?
Okay, very good question. Actually, unfortunately, even today in India, if you see, very routinely hydrogen peroxide, povidone iodine, Savlon, Usol, all these are very commonly used solutions which are a strict no in diabetic neuropathic foot patient. In fact, I would always say what one should be using on a wound, how gentle you should be in these wounds is, you should use something which can be used in the conjunctiva of the eye. So you have to be so gentle with this.
That's an interesting thing. I didn't know that.
So handle the wounds very gently, and then definitely the healing touch will be there. The wounds will start healing.
So this is what you're talking about when the wound started granulating. When it is infected, probably they can use the betadine, iodine solution.
Povidone, yes, but povidone over a long period of time has got a cytotoxic effect. Then if you really ask me for cleansing, we do have superoxide solutions which can be used where they have anti-biofilm activity. There are certain other agents or even dressings which have got anti-biofilm activity, de-sloughing activity, antimicrobial activity. So those advanced modalities, though it may initially appear as to be costlier, but when you talk about wound healing, if it is heals the wound a little faster, I think effectively we have saved the money also and saved the limb also.
Absolutely. So we also have other chronic ulcers
Yes.
apart from the diabetic foot. Diabetic foot probably today takes the majority
Yes.
in the chronic ulcer space. But we also have other chronic ulcers, and you have been dealing with it. It could
Yeah.
be a simple venous ulcers or incisional chronic ulcers,
Right.
kind of a thing. What technologies are useful in that, or is it the same technologies can be
More or less, yeah,
implemented
you
there?
can actually interpolate and use more or less the similar technologies in all the non-healing ulcers, because ultimately you have to get the ulcer into healing phase. That's our most important thing. So initially what I would recommend young physicians and surgeons is do a good thorough debridement, get the wound into from a chronic stage into acute phase, and then you start working on the wound. Then depending on the wound condition, what kind of a wound you are looking at, whether it is a mild, moderate or heavily exudating wound, whether it is obviously in which case it is going to be infected wound, then your dressing modality is going to change. So one has to also keep on changing the dressing modality. There is no one key to all the kinds of wounds, because
So when do you change a dressing modality? Like today there are like several dressings that are
Yeah.
available to manage the infection, to manage the granulation, also to epithelize the wound. When would you think that it's the time to change the my approach for wound healing?
Yeah, now see, when you look at the wound healing progression model, if you see there is a necrotic wound, we need to use some kind of hydrogel to donate moisture there to separate the eschar. The moment you have got that out, you see an underlying sloughy base. Of course, again I would put, as a surgeon, we are going to debride surgically. But for a physician, it may not be the case all across India. So then when it comes to sloughy, then they have to use some enzymatic debriding agents or some other debriding agent so that the slough can be removed. Once that is out, then obviously your dressing modality has to change. Then you are looking at a granulating wound. But if it is that point of time you feel it is infected, then you also need some antimicrobial like silver, which can be
Okay.
used to control the infection. But
In
the
a
mo-
granulating mode.
in a granulating wound also, if it is infected, it's not a healthy granulation.
Yeah.
But the moment you realize that now, okay, the wound is looking devoid of infection, and then you want obviously a faster wound healing, then you don't need any antimicrobial per se there, and then you are going to switch over to something which is going to accelerate the wound healing or promote the granulation tissue, wherein I can cover the wound a little faster by putting a graft or a
Yes,
flap.
yes. We have seen in our practice